Bones and joints of thorax. Introduction. The thorax is an osseocartilaginous cavity or cage for various viscera, providing them due support and protection. This cage is not static, but dynamic, as it moves at its various joints, increasing or decreasing the various diameters of the cavity for an extremely important process of respiration, which is life for all of us. Bones of thorax. Ribs or COSTAE. 1. There are 12 ribs on each side forming the greater part of the thoracic skeleton. The number may be increased by development of a cervical or a lumbar rib, or the number may be reduced to 11 by the absence of the 12th rib. 2. The ribs are bony arches arranged one below the other, Fig 13.1. The gaps between the ribs are called intercostal spaces, see Fig 12.1. The spaces are deeper in front than behind, and deeper between the upper than between the lower ribs. 3. The ribs are placed obliquely, the upper ribs being less oblique than the lower. The obliquity reaches. The ribs are placed obliquely, the upper ribs being less oblique than the lower. The obliquity reaches. 4. Gradually decreases to the 12th rib. The length of the ribs increases from the 1st to the 7th ribs, and then gradually decreases from the 8th to 12th ribs. The breadth of the ribs decreases from above downwards. In the upper 10 ribs the anterior ends are broader than the posterior ends. The first 7 ribs which are connected through their cartilages to the sternum are called true ribs, or vertebrosternal ribs. The remaining 5 are false ribs. Out of these the cartilages of the 8th, 9th, and 0/10th ribs are joined to the next higher cartilage and are known as vertebrochondral ribs. The anterior ends of the 11th and 12th ribs are free and are called floating ribs or vertebral ribs. 1. The first 2 and last 3 ribs have special features, and are atypical ribs. The 3rd to 9th ribs are typical ribs. Typical ribs. Side determination. 1. The anterior end bears a concave depression. The posterior end bears a head, a neck, and a tubercle. 2. The shaft is convex outwards and there is costal groove situated along the lower part of its inner surface, so that the lower border is thin and the upper border rounded. Features of typical rib. Each rib has 2 ends, anterior and posterior. Its shaft comprises upper and lower borders and outer and inner surfaces. The anterior sternal end is oval and concave for articulation with its costal cartilage. The posterior or vertebral end is made up of the following parts. 1. The head has 2 facets that are separated by a crest. The lower larger facet articulates with the body of the numerically corresponding vertebra while the upper smaller facet articulates with the next higher vertebra. 2. The neck lies in front of the transverse process of its own vertebra, and has 2 surfaces, anterior and posterior, and 2 borders, superior and inferior. The anterior surface of the neck is smooth. The posterior surface is rough. 3. The superior border or crest of the neck is thin. The inferior border is rounded. 4. The tubercle is placed on the outer surface of the rib at the junction of the neck and shaft. Its medial part is articular and forms the COSTAE transverse joint with the transverse process of the corresponding vertebra. The lateral part is non-articular. The shaft is flattened so it has 2 surfaces, outer and inner, and 2 borders, upper and lower. The shaft is curved with its convexity outwards. It is bent at the angle which is situated about 5 cm lateral to the tubercle. It is also twisted at the angle. 1. The outer surface, the angle is marked by an oblique line on the outer surface directed downwards and laterally. 2. The inner surface is smooth and covered by the pleura. This surface is marked by a ridge which is continuous behind with the lower border of the neck. The costal groove lies between this ridge and the inferior border. The costal groove contains the posterior intercostal vessels and intercostal nerve. 3. The upper border is thick and has outer and inner lips. 4. Anteriorly, the head provides attachment to the radiate ligament, and is related to the sympathetic chain and to the costal pleura. 5. The crest of the head provides attachment to the intra-articular ligament of the costovertebral joint. 6. Attachment to the neck. The anterior surface is covered by costal pleura. The inferior COSTAE transverse ligament is attached to the rough posterior surface. The two laminae of the superior COSTAE transverse ligament are attached to the crest of the neck. 7. The lateral non-articular part of the tubercle gives attachment to the lateral COSTAE transverse ligament. 8. Attachment on the shaft. The thoracolumbar fascia and the lateral fibers of the sacrospinalis muscle are attached to the angle. Medial to the angle, the levator COSTAE and the sacrospinalis are attached. About 5 cm from the anterior end there is an indistinct oblique line, known as the anterior angle, which separates the origins of the external oblique from serratus anterior in case of 5th to 8th ribs. The anterior 9 angle also separates the origin of external oblique from that of latissimus dorsi in case of 9th and 10th ribs. B. The internal intercostal muscle arises from the floor of the costal groove. The intercostal in IBS arises from the middle 2/4 of the ridge above the groove. The subcosphagus is attached to the inner surfaces of the lower ribs, see Fig 14.2. C. The external intercostal muscle is attached on the outer lip of the upper border, while the internal intercostal and intercostalis intimi are attached on the inner lip of the upper border. A typical rib ossifies in cartilage from, a primary center, for the shaft, which appears, near the angle, at about the 8th week of intrauterine life. B. 3 secondary centers, 1 for the head and 2 for the tubercle, which appear at puberty and unite with the rest of the bone after 20 years. First rib, identification, 1 It is shortest broad and most curved rib. 2 The shaft is not twisted. There is no vistal groove. 1 It is flattened from above downwards so that it has superior and inferior surfaces, and outer and inner borders. Side determination. 1 The anterior end is larger, thicker, and pitted. The posterior end is small and rounded. 2 The outer border is convex and not having costal groove. 3 The upper surface of the shaft is crossed obliquely by 2 shallow grooves separated by a ridge. The ridge is enlarged at the inner border of the rib to form the scalene tubercle. When the rib is placed on a horizontal plane, i.e. with the superior surface facing upwards, both the ends of the rib touch the surface. Features of second rib. 1 The anterior end is larger and thicker than that in the other ribs. It is continuous with the first costal cartilage. 2 The posterior end comprise the following. The head is small and rounded. It articulates with the body of first thoracic vertebra. B. The neck is rounded and directed laterally. 4. The tubercle is large. It coincides with the angle of the rib. It articulates with the transverse process of first thoracic vertebra to form the COSTAE transverse joint. 1 The body, has 2 surfaces, upper and lower, and 2 borders, outer and inner. The upper surface is marked by 2 shallow grooves, separated near the inner border by the scalene tubercle. The lower surface is smooth and has no costal groove. The outer border is convex, thick behind and thin in front. The inner border is concave. At segments and relations 1 Anteriorly, the neck is related from medial to lateral side to a sympathetic chain posterior intercostals vein superior intercostals artery ventral ramus of first thoracic nerve, mnemonic chain pulling a vein. 2 Superiorly, the neck is related to the deep cervical vessels. The 8th cervical nerve. 2 The anterior groove on the superior surface of the shaft lodges the subclavian vein, and the posterior groove lodges the subclavian artery and the lower trunk of the brachial plexus. 3 The structures attached to the upper surface of the shaft are, the origin 1 The subclavius muscle at the anterior end. The attachment of the costoclavicular ligament at the anterior end behind the subclavius. R. The insertion of the scalenus anterior on the scalene tubercle. D. The insertion of the scalenus median on the elongated rough area behind the groove for the subclavian artery. 4. The lower surface of the shaft is covered by costal pleura and is related near its outer border to the small first intercostal nerve, which is very small. 5. The outer border gives origin to the external intercostal muscle. The upper part of the first digitation of the serratus anterior, just behind the groove for the subclavian artery. The thick portion of the outer border is covered by the scalenus posterior. 6. The inner border gives attachment to the suprapleural membrane. 7. The tubercle gives attachment to the lateral COSTAE transverse ligament. Tubercle is a unique feature of the second rib. The inner surface of the shaft is smooth and concave. It faces more downwards than inwards. There is a short costal groove on the posterior part of this surface. The first rib ossifies from one primary center for the shaft and only two secondary centers, one for the head and the other for the tubercle. Otherwise its ossification is similar to that of one atypical rib. Second rib. Features. The features of the second rib are: 2. The length is twice that of the first rib. 3. The shaft is sharply curved, like that of the first rib. 4. The non-articular part of the tubercle is small. 5. The angle is slight and close to the tubercle. 6. The shaft has no twist. The outer surface is convex and faces more upwards than outwards. Near its middle it is marked by a large rough tubercle. This tubercle is a unique feature of the second rib. The inner surface of the shaft is smooth and concave. It faces more downwards than inwards. There is a short costal groove on the posterior part of this surface. The posterior part of the upper border has distinct outer and inner lips. The part of the outer lip just in front of the angle is rough. Attachments. 1. The rough tubercle on the outer surface gives origin to 1.5 digitations of the serratus anterior muscle. 2. The rough part of the upper border receive the insertion of the scalenus posterior. 10th rib. The 10th rib closely resembles a typical rib, but is one shorter. 2. Has only a single facet on the head, for the body of the 10th thoracic vertebra. 11th and 12th ribs. 11th and 12th ribs are short. They have pointed ends. The necks and tubercles are absent. The angle and costal groove are poorly marked in the 11th rib, and are absent in the 12th rib. Attachment and relations of the 11th and 12th ribs. 1. The capsular and radiate ligaments are attached to the head of the rib, Fig 13.6. The following are attached on the inner surface. The quadratus lumborum is inserted on the lower part of the medial half to 2/3 of this surface. The fascia covering the quadratus lumborum is also attached to this part of the rib. The internal intercostal muscle is inserted near the upper border. The costodiaphragmatic recess of the pleura is related to the medial 3/4 of the costal surface. The diaphragm takes origin from the anterior end of this surface. The following are attached to the outer surface: A. Attachment on the medial half, I. Costa transverse ligament. 2. Lumbocostal ligament. Lowest levator costae. Iliocostalis and longissimus parts of sacrospinalis. B. Attachments on the lateral half. A. Insertion of serratus posterior inferior. B. Origin of latissimus dorsi. Origin of external oblique muscle of abdomen. 2. The intercostal muscles are attached to the upper border. 3. The structures attached to the lower border are: A. Middle layer of the thoracolum or fascia. Lateral arcuate ligament, at the lateral border of the quadratus lumborum. Lumbocostal ligament near the head, extending to the transverse process of first lumbar vertebra. The 11th and 12th ribs ossify from one primary center for the shaft and one secondary center for the head. Costal cartilages. The costal cartilages represent the unossified anterior parts of the ribs. They are made up of hyaline cartilage. They contribute materially to the elasticity of the thoracic wall. The medial ends of the costal cartilages of the first 7 ribs are attached directly to the sternum. The 8th, 9th, and 10th cartilages articulate with one another and form the costal margin. The cartilages of the 11th and 12th ribs are small. Their ends are free and lie in the muscles of the abdominal wall. The direction of the costal cartilages is variable. As the first costal cartilage approaches the sternum, it descends a little. The second cartilage is horizontal. The third ascends slightly. The remaining costal cartilages are angular. They continue the downward course of the rib for some distance, and then turn upwards toward either the sternum or the next higher costal cartilage. Each cartilage has 2 surfaces, anterior and posterior, 2 borders, superior and inferior, and 2 ends, lateral and medial. Attachments. Anterior surface. One anterior surface of the first costal cartilage articulates with the clavicle and takes part in forming the sternoclavicular joint. It gives attachment to the sternoclavicular articular disc, see chapter 10. B. The joint capsule, the sternoclavicular ligament. The subclavius muscle. 2. The second to sixth costal cartilages give origin to the pectoralis major. 3. The remaining cartilages are covered by and give partial attachment to some of the flat muscles of the anterior abdominal wall. The internal oblique muscle is attached to the seventh, eighth, and ninth cartilages, posterior surface. 1. The first cartilage gives origin to the sternothyroid muscle. 2. The second to sixth cartilages receive the insertion of the sternocostalis. 3. The seventh to 12th cartilages give attachment to the transversus abdominis and to the diaphragm. 4. The medial end. 5. The borders give attachment to the internal intercostals muscles and external intercostals membranes of the spaces concerned. 1. The fifth to ninth cartilages articulate with one another at the points of their maximum convexity, to form synovial joints. Lateral end. The lateral end of each cartilage forms a primary cartilaginous joint with the rib concerned. Medial end. 1. The first cartilage forms a primary cartilaginous joint with the manubrium. 2. The second to seventh cartilages form synovial joints with the sternum. 1. The eighth, ninth, and 10th cartilages are connected to the next higher cartilage by synovial joints. The ends of the 11th and 12th cartilages are pointed and free. 2. Weakest area of rib is at S angle. This is the commonest of fracture. 3. Cervical rib occurs in 0.5% of persons. It may articulate with first rib or may have a free end. It may cause pressure on lower trunk of brachial plexus, resulting in paresthesia along the medial border of forearm and wasting of intrinsic muscles of hand, see Fig 12.14. It may also cause pressure on the subclavian artery. 4. In rickets there is inadequate mineralization of bone matrix at the growth plates due to increased bone resorption. Due to deposition of unmineralized matrix there is widening of the wrist and rachitic rosary, i.e. prominent costochondral junctions in thoracic cage. Sternum. The sternum is a flat bone, forming the anterior median part of the thoracic skeleton. In shape, it resembles a short sword. The upper part, corresponding to the handle. The middle part, resembling the blade, is called the body. The lowest tapering part forming the point of the sword is the xiphoid process or xiphosternum. The sternum is about 17 centimeters long. It is longer in males than in females. Manubrium. The manubrium is quadrilateral in shape. It is the thickest and strongest part of the sternum. It has two surfaces, anterior and posterior, and four borders, superior, inferior, and two lateral. The anterior surface is convex from side to side and concave from above downwards, Fig 13.10. The posterior surface is concave and forms the anterior boundary of the superior mediastinum. The superior border is thick, rounded and concave. It is marked by the suprasternal notch or jugular notch or interclavicular notch in the median part, and by the clavicular notch on each side. The clavicular notch articulates with the medial end of the clavicle to form the sternoclavicular joint. The inferior border forms a secondary cartilaginous joint with the body of the sternum. The manubrium makes a slight angle with the body, convex forwards, called the sternal angle of Lewis. The lateral border forms a primary cartilaginous joint with the first costal cartilage, and present a demifacet for synovial articulation with the upper part of the second costal cartilage. Attachments. 1. The anterior surface gives origin on either side to the pectoralis major. The sterna head of the sternocleidomastoid. The posterior surface gives origin to the sternohyoid in upper part and sternothyroid in lower part. The lower half of this surface is related to the arch of the aorta. The upper half is related to the left brachiocephalic vein, the brachiocephalic artery, the left common carotid artery and the left subclavian artery. The lateral portions of the surface are related to the corresponding lung and pleura. 2. The suprasternal notch gives attachment to the lower fibers of the interclavicular ligament, and to the two subdivisions of the investing layer O1 cervical fascia. 3. The margins of each clavicular notch give attachment to the capsule of the corresponding sternoclavicular joint. Body of the sternum. The body is longer, narrower and thinner than the manubrium. It is widest close to its lower end opposite the articulation with the fifth costal cartilage. It has two surfaces, anterior and posterior, two lateral borders, and two ends, upper and lower. 1. The inferior surface is nearly flat and directed forwards and slightly upwards. It is marked by 3 ill-defined transverse ridges, indicating the lines of fusion of the 4 small segments called sternobrae. 2. The posterior surface is slightly concave and is marked by less distinct transverse lines. 3. The lateral borders from synovial jointa with the 5 lower part of the second costal cartilage, the 3rd to 6th costal cartilages, and the upper half of the 7th costal cartilage, Fig 13.11. 3. The upper end forms a secondary cartilaginous joint with the manubrium, at the sternal angle. The lower end is narrow and forms a primary cartilaginous joint with the xiphisternum. Attachments. 1. The anterior surface gives origin on either side to the pectoralis major muscle. 2. The lower part of the posterior surface gives origin on either side to the sternocostalis muscle. On the right side of the median plane, the posterior surface is related to the anterior border of the right lung and pleura. On the left side, the upper 2 pieces of the body are related to the left lung and pleura, and the lower 2 pieces to the pericardium, Fig 13.12. 4. Between the facets for articulation with the costal cartilages, the lateral borders provide attachment to 4. The external intercostal membranes and to the internal intercostal muscles. Xiphoid process. The xiphoid process is the smallest part of the sternum. It is at first cartilaginous, but in the adult it becomes ossified near its upper end. It varies greatly in shape and may be bifid or perforated. It lies in the floor of the epigastric fossa. Attachments. 1. The anterior surface provides insertion to the medial fibers of the rectus abdominis, and to the aponeuroses of the external and internal oblique muscles of the abdomen. 2. The posterior surface gives origin to the diaphragm. It is related to the anterior surface of the liver. 3. The lateral borders of the xiphoid process give attachment to the aponeuroses of the internal oblique and transversus abdominis muscles. 4. The upper end forms a primary cartilaginous joint with the body of the sternum. 5. The lower end afford attachment to the linea alba. The sternum develops by fusion of 2 sternal plates formed on either side of the midline. The fusion of the 2 plates takes place in a craniocaudal direction. Manubrium is ossified from 2 centers appearing in 5th fetal month. First and second sternobrae ossify from 1 center appearing in 5th fetal month. Third and fourth sternobrae ossify from paired centers which appear in 5th and 6th months. These fuse with each other from below upwards during puberty. Fusion is complete by 25 years of age. The manubriosternal joint, which is a secondary cartilaginous joint, usually persists throughout life. The center for the xiphoid process appears during the 3rd year or later. It fuses with the body at about 40 years, Figs 13.13a and b. Bone marrow for examination is usually obtained by manubriosternal puncture, Fig 13.14. It is done in its upper half to prevent injury to arch of aorta which lies behind its lower half. The slight movements that take place at the manubriosternal joint are essential for movements of the ribs. In the anomaly called funnel chest, the sternum is depressed. In another anomaly called pigeon chest, there is forward projection of the sternum like the keel of a boat, and flattening of the chest wall on either side. For cardiac surgery, the manubrium and/or body of sternum need to be splitted in midline and the incision is closed with stainless steel wires. Sternum is protected from injury by attachment of elastic costal cartilages. Indirect violence may lead to fracture of sternum. Non-fusion of the sternal plates causes ectopia cordis, where the heart lies uncovered on the surface. Partial fusion of the plates may lead to vertebral column as a whole. The vertebral column is also called the spine, the spinal column, or backbone. It is the central axis of the body. It supports the body weight and transmits it to the ground through the lower limbs. The vertebral column is made up of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. In the thoracic, lumbar, and sacral regions, the number of vertebrae corresponds to the number of spinal nerves, each nerve lying below the corresponding vertebra. In the cervical region, there are 8 nerves, the upper 7 lying above the corresponding vertebrae and the 8th below the 7th vertebra. In the coccygeal region, there is only one coccygeal nerve. Sometimes the vertebrae are also grouped according to their mobility. The movable or true vertebrae include the 7 cervical, 12 thoracic, and 5 lumbar vertebrae, making a total of 24. 12 thoracic vertebrae have ribs attached to them. The fixed vertebrae include those of the sacrum and coccyx. The length of the spine is about 70 cm in males and about 60 cm in females. The intervertebral discs contribute 1/5 of the length of the vertebral column. As a result of variations in the width of the vertebrae, the vertebral column can be said to be made up of 4 pyramids, Fig 13.16a. This arrangement has a functional bearing. The narrowing of the vertebral column at the level of the disc between 4th thoracic and 5th thoracic vertebrae is partly compensated for by the transmission of weight to the lower thoracic region through the sternum and ribs. Curvatures. In sagittal plane, 1 primary curves are present at birth due to the shape of the vertebral bodies. The primary curves are thoracic and sacral, both of which are concave forwards. 2 secondary curves are postural and are mainly due to the shape of the intervertebral disc. The secondary or compensatory curves are cervical and lumbar, both of which are convex forwards. The cervical curve appears during 4 to 5 months after birth when the infant starts supporting its head. The lumbar curve appears during 12 to 18 months when the child assumes the upright posture, Figs 13.16b and c. In coronal plane, lateral. There is slight lateral curve in the thoracic region with its concavity towards the left. It is possible due to the greater use of the right upper limb and the pressure of the aorta. The curvatures add to the elasticity of the spine, and the number of curves gives it a higher resistance to weight than would be afforded by a single curve. Ports of a typical vertebra. A typical vertebra is made up of the following parts. 1. The body lies anteriorly. It is shaped like a short cylinder, being rounded from side to side and having flat upper and lower surfaces that are attached to those of adjoining vertebrae by intervertebral discs. 2. The pedicles, right and left, are short rounded bars that project backwards, and somewhat laterally, from the posterior aspect of the body. 3. Each pedicle is continuous, posteromedially, with a vertical plate of bone called the lamina. The laminae of the 2 sides pass backwards and medially to meet in the midline. The pedicles and laminae together constitute the vertebral or neural arch. 4. Bounded anteriorly by the posterior aspect of the body, on the sides by the pedicles, and behind by the lamina, there is a large vertebral foramen. Each vertebral foramen forms a short segment of the vertebral canal that runs through the whole length of the vertebral column and lodges the spinal cord. 5. Passing backwards and usually downwards from the junction of the 2 laminae there is the spine or spinous process. Passing laterally and usually somewhat downwards from the junction of each pedicle and the corresponding lamina, there is a transverse process. The spinous and transverse processes serve as levers for muscles acting on the vertebral column. From a morphological point of view, the transverse processes are made up of 2 elements, the transverse element and the costal element. In the thoracic region, the 2 elements remain separate, and the costal elements form the ribs. In the rest of the vertebral column, the derivatives of costal element are different from those derived from transverse element. This is shown in Table 13.1. 6. Projecting upwards from the junction of the pedicle and the lamina there is on either side, a superior articular process, and projecting downwards there is an inferior articular process. Each process bears a smooth articular facet, the superior facet of one vertebra articulates with the inferior facet of the vertebra above it. 7. The pedicle is much narrower in vertical diameter than the body and is attached nearer its upper border. As a result, there is a large inferior vertebral notch below the pedicle. Above the pedicle there is a much shallower superior vertebral notch. The superior and inferior notches of adjoining vertebrae join to form the intervertebral foramina, which give passage to the dorsal and ventral rami of the spinal nerves emerging from the spinal cord. Thoracic vertebrae. Identification. The thoracic vertebrae are identified by the presence of costal facets on the sides of the vertebral bodies. The costal facets may be two or only one on each side. There are 12 thoracic vertebrae, out of which the 2nd to 8th are typical, and the remaining 5, 1st, 9th, 10th, 11th, and 12th, are atypical. Typical thoracic vertebra. 1. The body is heart-shaped with roughly the same measurements from side to side and antero-posteriorly. On each side, it bears 2 costal demi-facets. The superior costal demi-facet is larger and placed on the upper border of the body near the pedicle. It articulates with the head of the numerically corresponding rib. The inferior costal demifacet is smaller and placed on the lower border in front of the inferior vertebral notch. It articulates with the next lower rib. The vertebral foramen is comparatively small and circular. The vertebral archwires, the pedicles, are directed straight backwards. The superior vertebral notch is shallow, while the inferior vertebral notch is deep and conspicuous. The laminae overlap each other from above. The superior articular processes project upwards from the junction of the pedicles and laminae. The articular facets are flat and are directed backwards. This direction permits rotatory movements of the spine. The inferior articular processes are fused to the laminae. Their articular facets are directed forwards. The transverse processes are large, and are directed laterally and backwards from the junction of the pedicles and laminae. The anterior surface of each process bears a facet near its tip, for articulation with the tubercle of the corresponding rib. In the upper 6 vertebrae, the costal facets on the transverse processes are concave, and face forwards and laterally. In lower 6, the facets are flat and face upwards, laterally, and slightly forwards. The spine is long, and is directed downwards and backwards. The 5th to 9th spines are the longest, more vertical, and overlap each other. The upper and lower spines are less oblique in direction. Attachments. The upper and lower borders of the body give attachment, in front and behind respectively, to the anterior and posterior longitudinal ligaments. 2. The upper borders and lower parts of the anterior surfaces of the laminae provide attachment to the ligamenta flava. 3. The transverse process gives attachment to the lateral costa transverse ligament at the tip. The superior cofafrans reus ligament along the lower border. The inferior costa transverse ligament along the anterior surface. The inferior ligaments and muscles to upper and lower borders. The levator costae on posterior surface. 4. The spines give attachment to the supraspinous and interspiraeus ligaments. They also give attachment to several muscles including the trapezius, the rhomboids, the latissimus dorsi, the serratus posterior superior and the serratus posterior inferior, and many deep muscles of the back. First, thoracic vertebra. 1. The body of this vertebra resembles that of a cervical vertebra. It is broad and not heart-shaped. Its upper surface is lipped laterally and beveled anteriorly. The superior costal facet on the body is complete, Fig 13.21. It articulates with the head of the first rib. The inferior costal facet is a demifacet for the second rib. 2. The spine is thick, long and horizontal. 2. The superior vertebral notches are well marked, as in cervical vertebrae. 9th thoracic vertebra. The 9th thoracic vertebra resembles a typical thoracic vertebra except that the body has only the superior costal demifacets. The inferior costal facets are absent. 10th thoracic vertebra. The 10th thoracic vertebra resembles a typical thoracic vertebra except that the body has a single complete superior costal facet on each side, extending onto the root of the pedicle. 11th thoracic vertebrae. 1. The body has a single large costal facet on each side, extending onto the upper part of the pedicle. 2. The transverse process is small, and has no articular facet. Sometimes it is difficult to differentiate between 10th thoracic and 11th thoracic vertebrae. 12th thoracic vertebra. 1. The shape of the body, pedicles, transverse processes and spine are similar to those of a lumbar vertebra. However, the body bears a single costal facet on each side, which lies more on the lower part of the pedicle than on the body. 2. The transverse process is small and has no facet, but has superior, interior, and lateral tubercles. 3. The inferior articular facets are lumbar in type. These are everted and are directed laterally, but the superior articular facets are thoracic in type. The superior coffrans rears ligament along the lower border. The inferior COSTAE transverse ligament along the anterior surface. The inferior respiration ligament and muscles of upper and lower borders. The levator COSTAE on the posterior surface. 5. The spines give attachment to the supraspinous and interspiraeus ligaments. They also give attachment to several muscles including the trapezius, the rhomboids, the latissimus dorsi, the serratus posterior superior and the serratus posterior inferior, and many deep muscles of the back. 1st thoracic vertebra. 3. The body of this vertebra resembles that of a cervical vertebra. It is broad and not heart-shaped. Its upper surface is lipped laterally and beveled anteriorly. The superior costal facet on the body is complete, Fig 13.21. It articulates with the head of the first rib. The inferior costal facet is a demifacet for the second rib. 2. The spine is thick, long, and nearly horizontal. 4. The superior vertebral notches are well marked, as in cervical vertebrae. 9th thoracic vertebra. The 9th thoracic vertebra resembles a typical thoracic vertebra except that the body has only the superior costal demifacets. The inferior costal facets are absent. 10th thoracic vertebra. The 10th thoracic vertebra resembles a typical thoracic vertebra except that the body has a single complete superior costal facet on each side, extending onto the root of the pedicle. 11th thoracic vertebrae. 3. The body has a single large costal facet on each side, extending onto the upper part of the pedicle. 4. The transverse process is small, and has no articular facet. Sometimes it is difficult to differentiate between 10th thoracic and 11th thoracic vertebrae. 12th thoracic vertebra. 4. The shape of the body, pedicles, transverse processes and spine are similar to those of a lumbar vertebra. However, the body bears a single costal facet on each side, which lies more on the lower part of the pedicle than on the body. 5. The transverse process is small and has no facet, but has superior, interior, and lateral tubercles. 6. The inferior articular facets are lumbar in type. These are everted and are directed laterally, but the superior articular facets are thoracic in type. The ossification is similar to that of a typical vertebra. It ossifies in cartilage from 3 primary and 5 secondary centers. The 3 primary centers, one for the centrum and one for each half of the neural arch, appear during 8th to 9th week of fetal life. At birth the vertebra consists of 3 parts, the centrum and 2 halves of the neural arch. The 2 halves of the neural arch fuse posteriorly during the first year of life. The neural arch is joined with the centrum by the neurocentral synchondrosis. Bony fusion occurs here during the 3rd to 6th year of life. 5 secondary centers, one for the upper surface and one for the lower surface of the body, one for each transverse process, and one for the spine, appear at about the 15th year and fuse with the rest of the vertebra at about the 25th year. Failure of fusion of 2 halves of neural arch results in spina bifida. Sometimes the body ossifies from 2 primary centers, and if one center fails to develop, one half, right or left of the body is missing. This results in a hemivertebra and lateral bend in the vertebral column or scoliosis. In young adults, the discs are very strong. However, after the 2nd decade of life, degenerative changes set in, resulting in weakness of the annulus fibrosus. When such a disc is subjected to strain, the annulus fibrosus may rupture, leading to prolapse of the nucleus pulposus. This is commonly referred to as disc prolapse. It may occur even after a minor strain. In addition to prolapse of the nucleus pulposus, internal derangements of the disc may also take place. Disc prolapse is usually posterolateral. The prolapsed nucleus pulposus presses upon adjacent nerve roots and gives rise to pain that radiates along the distribution of the nerve. Such pain along the course of the sciatic nerve is called sciatica. Motor effects, with loss of power and reflexes, may follow. Disc prolapse occurs most frequently in the lower lumbar region, Fig 13.23. It is also common in the lower cervical region from 5th to 7th cervical vertebrae. Joints of thorax. Manubriosternal joint. Manubriosternal joint is a secondary cartilaginous joint. It permits slight movements of the body of the sternum on the manubrium during respiration. Costovertebral joints. The head of a typical rib articulates with its own vertebra, and also with the body of the next higher vertebra, to form two plain synovial joints separated by an intra-articular ligament. This ligament is attached to the ridge on the head of the rib and to the intervertebral disc. Other ligaments of the joint include a capsular ligament and a triradiate ligament. The middle band of the triradiate ligament forms the hypochordal bow, Fig 13.5, uniting the joints of the two sides. COSTAE. Transverse joints. The tubercle of a typical rib articulates with the transverse process of the corresponding vertebra to form a synovial joint. The capsular ligament is strengthened by three COSTAE transverse ligaments. The superior COSTAE transverse ligament has two laminae which extend from the crest on the neck of the rib to the transverse process of the vertebra above. The inferior COSTAE transverse ligament passes from the posterior surface of the neck to the transverse process of its own vertebra. The lateral COSTAE transverse ligament connects the lateral non-articular part of the tubercle to the tip of the transverse process of its own vertebra. The articular facets on the tubercles of the upper six ribs are convex, and permit rotation of the neck of the rib for pump handle movements, Fig 13.24. Rotation of rib neck backwards causes elevation of second to sixth ribs with moving forwards and upwards of the sternum. This increases the anteroposterior diameter of the thorax, Fig 13.25. The articular surfaces of the 7th to 10th ribs are flat, permitting up and down gliding movements or bucket handle movements of the lower ribs. When the neck of 7th to 10th ribs moves upwards, backwards, and medially, the result is increase in infrasternal angle. This causes increase in transverse diameter of thorax, Fig 13.26. For explanation of the terms pump handle and bucket handle movements, see respiratory movements. Costochondral joints. Each rib is continuous anteriorly with its cartilage, to form a primary cartilaginous joint. No movements are permitted at these joints. Chondrosternal joints. The first chondrosternal joint is a primary cartilaginous joint, it does not permit any movement. This helps in the stability of the shoulder girdle and of the upper limb. The 2nd to 7th costal cartilages articulate with the sternum by synovial joints. Each joint has a single cavity except in the second joint where the cavity is divided in two parts. The joints are held together by the capsular and radiate ligaments. Interchondral joints. The 5th to 9th costal cartilages articulate with one another by synovial joints. The 10th cartilage is united to the 9th by fibrous tissue. The movements taking place at the various joints described above are considered under respiratory movements. Intervertebral joints. Adjoining vertebrae are connected to each other at three joints. There is a median joint between the vertebral bodies, and two joints right and left between the articular processes. The joints between the articular processes are plain synovial joints. The joint between the vertebral bodies is a symphysis, secondary cartilaginous joint. The surfaces of the vertebral bodies are lined by thin layers of hyaline cartilage. Between these layers of hyaline cartilage, there is a thick plate of fibrocartilage which is called the intervertebral disc. Intervertebral discs. These are fibrocartilaginous discs which intervene between the bodies of adjacent vertebrae, and bind them together. Their shape corresponds to that of the vertebral bodies between which they are placed. The thickness of the disc varies in different regions of the vertebral column and in different parts of the same disc. In the cervical and lumbar regions, the discs are thicker in front than behind, while in the thoracic region they are of uniform thickness. The discs are thinnest in the upper thoracic region, and thickest in the lumbar region. The discs contribute about 1/5 of the length of the vertebral column. The contribution is greater in the cervical and lumbar regions than in the thoracic region. Each disc is made up of the following two parts. 1. The nucleus pulposus is the central part of the disc. It is soft and gelatinous at birth. It is kept under tension and acts as a hydraulic shock absorber. With advancing age, the elasticity of the disc is much reduced, Figs 13.27a and c. 2. The annulus fibrosus forms the peripheral part of the disc. It is made up of a narrower outer zone of collagenous fibers and a wider inner zone of fibrocartilage. The fibers form laminae that are arranged in the form of incomplete rings. The rings are connected by strong fibrous bands. The outer collagenous fibers blend with the anterior and posterior longitudinal ligaments. Functions. 1. The intervertebral discs give shape to the vertebral column. 2. They act as a remarkable series of shock absorbers or buffers. 3. Because of their elasticity they allow slight movement of vertebral bodies on each other, more so in the cervical and lumbar regions. When the slight movements at individual discs are added together, they become considerable. Ligaments connecting adjacent vertebrae. Apart from the intervertebral discs and the capsules around the joints between the articular processes, adjacent vertebrae are connected by several ligaments which are as follows. 1. The anterior longitudinal ligament passes from the anterior surface of the body of one vertebra to another. Its upper end reaches the basilar part of the occipital bone, Fig 13.27a. 2. The posterior longitudinal ligament is present on the posterior surface of the vertebral bodies within the vertebral canal. Its upper end reaches the body of the axis vertebra, beyond which it is continuous with the membrana tectoria. The intervertebral ligaments connect adjacent transverse processes. The interspinous ligaments connect adjacent spines. The supraspinous ligaments connect the tips of the spines of vertebrae from the 7th cervical to the sacrum. In the cervical region, they are replaced by the ligamentum nuchae. The ligaments fora, singular equals ligamentum flavum, connect the laminae of adjacent vertebrae. They are made up mainly of elastic tissue. Movements of the vertebral column. Movements between adjacent vertebrae occur simultaneously at all the joints connecting them. Movement between any two vertebrae is slight. However, when the movements between several vertebrae are added together, the total range of movement becomes considerable. The movements are those of flexion, extension, lateral flexion, and a certain amount of rotation. The range of movement differs in different parts of the vertebral column. This is influenced by the thickness and flexibility of the intervertebral discs and by the orientation of the articular facets. Flexion and extension occur freely in the cervical and lumbar region, but not in the thoracic region. Rotation is free in the thoracic region, and restricted in the lumbar and cervical regions. Introduction. The lungs expand during inspiration and retract during expiration. These movements are governed by the following two factors. Alterations in the capacity of the thorax are brought about by movements of the thoracic wall. Increase in volume of the thoracic cavity creates a negative intrathoracic pressure which sucks air into the lungs. Movements of the thoracic wall occur chiefly at the costovertebral and manubriosternal joints. 2. Elastic recoil of the pulmonary alveoli and of the thoracic wall expels air from the lungs during expiration. Principles of movements. 1. Each rib may be regarded as a lever, the fulcrum of which lies just lateral to the tubercle. Because of the disproportion in the length of the two arms of the lever, the slight movements at the vertebral end of the rib are greatly magnified at the anterior end, Fig 13.28. The anterior end of the rib is lower than the posterior end. Therefore, during elevation of the rib, the anterior end also moves forwards. This occurs mostly in the vertebrosternal ribs. In this way, the anteroposterior diameter of the thorax is increased. Along with the up and down movements of the 2nd to 6th ribs, the body of the sternum also moves up and down, called pump handle movements, Fig 13.29. This results in formation of sternal angle. 1. The middle of the shaft of the rib lies at a lower level than the plane passing through the two ends. Therefore, during elevation of the rib, the shaft also moves outwards. This causes increase in the transverse diameter of the thorax. Such movement occur in the vertebrochondral ribs and are called bucket handle movements. 2. The thorax resembles a cone, tapering upwards. As a result, each rib is longer than the next higher rib. On elevation, the larger lower rib comes to occupy the position of the smaller upper rib. This also increases the transverse diameter of the thorax, Fig 13.30. 2. Vertical diameter is increased by the piston movements of the thoraco-abdominal diaphragm. Summary of the factors producing increase in diameters of the thorax. The anteroposterior diameter is increased. 1. Mainly by the pump handle movements of the sternum brought about by elevation of the vertebrosternal 2nd to 6th ribs. 2. Partly by elevation of the 7th to 10th vertebrochondral ribs. The transverse diameter is increased, 1. Mainly by the bucket handle movements of the 7th to 10th vertebrochondral ribs. 2. Partly by elevation of the 2nd to 6th vertebrosternal ribs. The vertical diameter is increased by descent of the diaphragm as it contracts. This is called piston mechanism. During inspiration, the diaphragm contracts and it comes down by 2 centimeters. It is aided by relaxation of muscles of anterior abdominal wall. During expiration, abdominal muscles contract and diaphragm is pushed upwards. It facilitates in inspiration of at least 400 ml of air during each contraction. In females, respiration is thoraco-abdominal and in males it is abdominothoracic type. Respiratory muscles. For inspiration, diaphragm, external intercostal muscle and interchondral part of internal intercostal of contralateral side. Deep inspiration, erector spinae, scalene muscles, pectoral muscles. For expiration, passive process. Forced expiration, muscles of anterior abdominal wall. Respiratory movements during different types of breathing. Inspiration 1. Quiet inspiration. The anteroposterior diameter of the thorax is increased by elevation of the 2nd to 6th ribs. The first rib remains fixed. The transverse diameter is increased by elevation of the 7th to 10th ribs. The vertical diameter is increased by descent of the diaphragm. Deep inspiration. Movements during quiet inspiration are increased. The first rib is elevated directly by the scalene, and indirectly by the sternocleidomastoid. The concavity of the thoracic spine is reduced by the erector spinae. 1. Forced inspiration. All the movements described are exaggerated. The scapulae are elevated and fixed by the trapezius, the levator scapulae and the rhomboids, so that the serratus anterior and the pectoralis minor muscles may act on the ribs. The action of the erector spinae is appreciably increased. Expiration. 1. Quiet expiration. The air is expelled mainly by the elastic recoil of the chest wall and pulmonary alveoli, and partly by the tone of the abdominal muscles. 2. Deep and forced expiration. Deep and forced expiration is brought about by strong contraction of the abdominal muscles and of the latissimus dorsi. Clinical anatomy. In dyspnoea or difficulty in breathing, the patients are most comfortable on sitting up, leaning forwards and fixing the arms. In the sitting posture, the position of diaphragm is lowest, allowing maximum ventilation. Fixation of the arms fixes the scapulae, so that the serratus anterior and pectoralis minor may act on the ribs to good advantage. The height of the diaphragm in the thorax is variable according to the position of the body and tone of the abdominal muscles. It is highest on lying supine, so the patient is extremely uncomfortable, as he/she needs to exert immensely for inspiration. The diaphragm is lowest while sitting. The patient is quite comfortable as the effort required for inspiration is the least. The diaphragm is midway in position while standing, but the patient is too ill or exhausted to stand. So dyspnoic patients feel comfortable while sitting, Figs 13.31a to c. Most prominent role in respiration is played by diaphragm. Respiration occurs in 2 phases: inspiration active phase of 1 second, expiration passive phase of 3 second. In young children, up to 2 years of age, The thoracic cavity is almost circular in cross-section, so the scope for anteroposterior or side-to-side expansion is limited. The type of respiration in children is abdominal. In women of advanced stage of pregnancy, descent of diaphragm is limited, so the type of respiration in them is mainly thoracic mnemonic structures in COSTAE/GRO or VAN from above downwards. Posterior intercostal vein. Posterior intercostal artery. Intercostal nerve. Structures on neck of first rib van from medial to lateral side, posterior intercostal vein. Superior intercostal artery. 1st thoracic nerve. Vertebrae, recognizing a thoracic from lumbar, presence of costal facets on the sides of the body and transverse process. Shape of the vertebral body, thoracic is heart-shaped body, since your heart is in your thorax. Lumbar is kidney-shaped body, since kidneys are in lumbar area, the spine is long and oblique. Sternum forms joints with, 1 manubriosternal joint secondary cartilaginous. 3 joints between sternebrae primary cartilaginous. 1 joint between sternum and xiphoid process primary cartilaginous. Sternum forms 2 joints with clavicles of the 2 sides. Saddle type of synovial joint. It articulates with 1st to 7th costal cartilages on each side, forming a total of 14 joints plain synovial except 1st chondrosternal, which is synchondrosis. A typical thoracic vertebra forms following joints. Body of 1 vertebrae with body of vertebra above and body of vertebra below secondary cartilaginous joint, 2 joints. Lower larger part of head of corresponding rib for the demifacet along the upper border of the body on each side, 2 joints. Upper smaller part of head of a lower rib for the demifacet along the lower border of the body on each side, 2 joints. Superior articular processes on each side with the inferior articular processes of the vertebra above, 2 joints. Inferior articular processes on each side with the superior articular processes of the vertebra below, 2 joints. Transverse process of the vertebra with the articular part of the tubercle of the rib on each side, 2 joints. Body of the vertebra with the pedicle of the vertebra on each side. These are primary cartilaginous joints, 2 joints. Thus there are 14 joints which a typical thoracic vertebra makes. 3 secondary cartilaginous joints, 2 primary cartilaginous joints. 4 10 plain joints of synovial variety. 5 The rib are arched bones. Joint formed by a typical rib are, posterior end or head of a typical rib articulates with 2 adjacent vertebrae, corresponding 1 and 1 above it and the intervening intervertebral disc. The articular part of the tubercle articulates with transverse process of corresponding vertebra. The anterior part of the shaft of rib continues as the costal cartilage. It is primary cartilaginous joint. A costal cartilage forms plain synovial joint with the side of sternum. Respiratory movements produced by movements of thoraco-abdominal diaphragm are called abdominal respiration. Respiratory movements produced by movements of intercostal muscles is called thoracic respiration. During pranayama, deep regulated and smooth breathing occurs. Which diameters increase during deep breathing? ANS. The anteroposterior diameter increases by pump handle movement of the sternum. The transverse diameter increases by the bucket handle movement of the 710 ribs. The vertical diameter increases by piston movement of the thoraco-abdominal diaphragm. During inspiration, the vertical diameter increases by 3 to 5 centimeters, and during expiration, the vertical diameter decreases. Principles of movements. 1. Each rib may be regarded as a lever, the fulcrum of which lies just lateral to the tubercle. Because of the disproportion in the length of the arms of the lever, the slight movements at the vertebral end of the rib are greatly magnified at the anterior end, Fig 13.28. 2. The anterior end of the rib is lower than the posterior end. Therefore, during elevation of the rib, the anterior end also moves forwards. This occurs mostly in the vertebrosterile ribs. In this way, the anteroposterior diameter of the thorax is increased. Along with the up and down movements of the 2nd to 6th ribs, the body of the sternum also moves up and down, called pump handle movements, Fig 13.29. Clinico-anatomical problem 3. The middle of the shaft of the rib lies at a lower 1xe1 than the plane passing through the two ends. Therefore, during elevation of the rib, the shaft also moves outwards. This causes increase in the transverse diameter of the thorax. Such movements occur in the vertebracondylar ribs, and are called bucket handle movements. 4. The thorax resembles a cone, tapering upwards. As a result, each rib is longer than the next higher rib. On elevation, the larger lower rib comes to occupy the position of the smaller upper rib. This also increases the transverse diameter of the thorax, Fig 13.30. Contraction of the diaphragm with relaxation of anterior abdominal wall muscles increases the vertical diameter. Up and down movements as a result of contraction and relaxation of thoraco-abdominal diaphragm can alter the vertical diameter of the thoracic cavity. This movement is called piston movement.